which when you get to practice, I think you would end up learning faster. But I don't think it'll ever truly replace the apprenticeship experience, especially in surgery, because it's such a hands-on thing. However, having said that, that's VR. And so augmented reality is where I think can make that difference with things like this, where you have, you know, holographic hands in your real space and is trying to mimic that apprenticeship experience. But at the same time, with something that's so complex like surgery, having like the mentor being able to give you real-time feedback is invaluable. And I don't think that can be replaced. But hopefully these tools can make it easier.
So you showed us an experiment. I was wondering, can you say a little bit more about the experiment, and in particular about the different motions that you learned, and why the number of participants are rather low? So it's no problem, but I was wondering why this is the case.
Right. So I guess that was two questions. The first question was how did I come up with the hand motions? The hand motions that you saw here were generic hand motions that I had randomly created just to do that proof of concept to see if, well, can people learn hand motions from a pair of holographic hands? Because if they can't, then it's not worth it for me to put all this effort into developing the hands for specific applications. However, having said that, these hand motions do integrate skills that you would see in skills that you would teach in surgery, for example, like depth perception or hand motions that require more dexterity. And in terms of the participants, those were just people in my lab that were available at that time. So I'd like to have more participants, but it's like I could have actually brought the HoloLens here, and it would have been very easy to set up.
So what would be your follow-up experiment in a sense?
Yes, so the two applications that I was working on is the one-handed square knot tie and also sign language, so those will involve more participants and studies coming up.
Thank you very much.
Thank you.
And now we have Peter Chang on the medical imaging and biomedical diagnostics theme. Welcome.
Thank you. So I want to thank the organizers of this conference first here for this excellent opportunity to present some of my work on the evaluation of deep learning in head CTs. Now, to give you guys a sense of the problem scope, head CTs are by far the most common type of cross-sectional imaging ordered, accounting for over half of all the CT exams and several $1 billion in just the United States alone. Now, it turns out that there's a couple key features that make head CTs a particularly effective target and potential for deep learning. The first is, of course, there's a clinical need, so delay in interpretation on average of several hours. And importantly, the vast majority of all CTs are actually done just to exclude a single pathology, that of acute blood. Now, we've heard quite a bit about deep learning throughout this entire conference, and in the world of medical imaging, it's actually quite common nowadays to hear reports of reasonable accuracies using standard off-the-shelf architectures. However, to date, few, if any, tools exist with near 100% human accuracy in the detection of even a simple radiographic abnormality. In part, the reasons here relate to the relatively small medical imaging data sets, but also importantly, the fact that medical images are fundamentally different than their non-medical counterparts in terms of matrix size, bit depth, 3D as opposed to 2D volumes. And it turns out that instead of trying to force this data to fit the existing architectures, few, if any, groups are actually looking instead to tailor the algorithms to the data. And so that's what we set out to do. We started here with just under 6,000 3D volumes, yielding over 250,000 studies, images for evaluation, about 5% of which contain hemorrhages, which reflects the underlying population. Now, importantly, instead of a traditional classifier approach, we decided to reframe the question in terms of object localization, specifically a technique known as semantic segmentation, requiring expensive voxel-level annotation. While time-consuming, we justified this cost by simply trying to maximize our overall algorithm accuracy. This is an overview of the network architecture, which is based on a specialized network for segmentation known as the UNet, with several key modifications, the most important here being the hybrid 3D, 2D approach. The idea here is that as a physician, I know that it may be impossible to make a diagnosis on just a single slice. And so we actually build this explicitly into our model, where prediction at any given slice is actually taken into account the contextual information from 2 slices immediately above and below the field of interest. So these are our results, which we're quite pleased with. Again, just under 6,000 patients with only 2 missed cases of hemorrhage in the entire data set. This yields an accuracy, AUC, sensitivity, and specificity all over 99%. In addition, based on this segmentation approach, we can also predict hemorrhage volume with over 99.9% correlation with human experts. And finally, given architectural decisions, the algorithm is quite fast, requiring less than a fraction of a second for prediction from raw, unprocessed DICOM volumes. Again, we have 2 false negatives in the entire data set, and these are the 2. For the clinicians out there, you'll probably agree with me that these are relatively subtle hemorrhages, with the one on the right here being a potentially subjective call. These are some of the false positives. In general, these were all very, very small and tended to occur in patients with a degree of rotation or patient motion. In terms of future directions, I'm pleased to announce, actually, just in the past week, we've expanded the study to over 10,000 patients, including all sorts of extra-axial hemorrhages, including the epidurals, subdurals, and subarachnoids, with very high accuracy. In addition, the volumes that you can generate using this tool have a direct clinical correlation with clinical outcomes, including prediction of the modified Rankin score, as well as patient disposition status. And finally, what we're actually most excited for is that we're in fact IRB approved now at a few different institutions across the country for prospective validation of this tool, with the idea here being that it simply identifies all the positive cases and pushes it to the top of the list, helping reduce overall effective turnaround time. And that's it.
So I might start off. So this is a fantastic results, obviously. One of the challenges with this class of interpretation is you may, for some tasks, need to know anatomy. And at the moment, you're not exploiting anatomical knowledge. So can you give me a sense of whether you've picked an easy problem or this is a generalizable approach?
It is a generalized approach. In fact, there's a subset of analysis that we actually did where we did try to incorporate some of that anatomic information in the form of co-registered maps. So that was one experiment that we did early on, especially with a small data set. When you have a few hundred cases, that was a much better overall performing approach. But I think it turns out when you scale to all the types of anatomy and things that the algorithm can see and give it that information during training time, that all that extra sort of special pre-processing and additional information becomes less important.
If you have a patient that comes in and gets a CT to be evaluated, and so the algorithm is looking for a bleed, and so the patient doesn't have a bleed, but what about if there's a tumor or an AVM or something? Will that be missed?
Correct, yeah. So this problem is very hyper-focused, which is actually sort of the state of a lot of deep learning research right now. We tend to focus on a very narrow application. The goal eventually will be to go down the list. We have essentially a lot of high priority urgent findings that we want to knock off one by one. This was simply the first one on the list because it was the most common and simple thing to do, but certainly the same approach can be sort of applied to all the different pathologies, and that's something we're exploring right now.
Sort of a follow-on to that question, you did mention epidurals and subdurals. Were they differentiated or identified? from IPH?
So they're all hemorrhages. So all the hemorrhages were identified as hemorrhages. Although the new data set with the extraaxial hemorrhages, they were actually treated a little differently. So again, for clinicians out there, subarachnoid hemorrhages in particular tend not to work well with a pure segmentation approach because there's quite a bit of subjectivity in determining where exactly the hemorrhage is. In that case, a more rough, coarse localization tended to work a little bit better. But again, sort of similar variations of the theme, yes.
And secondly, tremendous accuracy. How do you actually see this being used?
Yeah, so the two potential use cases we see, one, I think the most salient would be as a triage tool. So in very rural parts of the United States and outside, especially in the after-hours setting, there's no 24-hour radiology coverage, and CT scans simply are read sort of as they come in, sometimes delayed until the next morning. So tools like this can be extremely beneficial to make sure that at least all the positive cases are read and basically signed off by a practicing radiologist. The second thing we did, which we didn't really have time to go into too much detail here, but there were about 20 cases out of 6,000 where the algorithm actually picked up a hemorrhage that we initially labeled negative. We did this through an NLP search using the reports, and if you go back, there are in fact actually very questionable areas. That last slide I actually showed one. And so that's sort of the other area, to basically proofread the radiologist before you sign it off. If it sees something suspicious, it'll flag it and say, are you sure, do you want to take a second look at this particular area and help limit overall medical errors.
For all the bleeds that required surgical intervention or some type of procedure, it was 100%, is that correct for those?
If it's large enough and if there's enough complications, mass effect, things like that, but a large proportion, yes.
I think you're done. Thank you very much.
All right, thank you.
Thank you.
So we'll be moving on now to Hamilton Baker. And Hamilton is presenting in the theme of robotic technology and virtual assistants. Welcome.
All right. I just want to start by saying thank you. It's been a fantastic conference. Really a pleasure to be here and to have this opportunity to present my work. So just a little bit of background. I'm an interventional pediatric cardiologist, and I love my job. I get to do some really, really neat stuff. I close holes in kids' hearts, work with patients all the way from the day they're born until into later years. And you know, I could go on and on about how much I love it, but there are a few things that I don't like about it, and the main one is radiation. Cardiac catheterization requires nearly constant fluoroscopy, and fluoroscopy, as you can see on the left there, it equals radiation. So while I'm doing my procedures, my patient, myself, and the staff is all exposed to harmful ionizing radiation. Another thing I don't love about my job is human error. It's undeniable in medicine, and it's an undeniable source of morbidity and mortality in cardiac catheterization. But what if we could get rid of both of these things, or at least attenuate them with one solution? And that's what inspired me to come up with the CathBot project. The ultimate goal of which is a self-directed robot capable of performing remotely supervised cardiac catheterizations with little to no ionizing radiation. And as most of my ideas started, it was on cocktail napkins. These are not actually cocktail napkins if you look closely enough, but looks like I probably had some cocktails if you look at the left drawing. A little bit like a stick figure taking on a squid or something. But these eventually became more and more sophisticated and led me to a blueprint, which I'll go through quickly here, this simplified version of it. The first stage is that CathBot acquires pre-procedural imaging data that is acquired with fiducial markers on the patient. Gets this from the EMR database, and it takes all of these scans, be it MRI, ultrasound, et cetera, and creates a 3D model of the patient's anatomy. It then co-registers this model with the actual patient through the use of the electromagnetic tracking system and the magnetic field. You can see the patient has the fiducial markers. Temporal gating and syncing is achieved through ECG and respiratory gating. And catheter position is continually monitored by the electromagnetic tracking system. Manipulation of the catheter is accomplished by selected catheter manipulation algorithms that are sent to and carried out by the robotic arm unit. So when you take all this together, the CathBot knows exactly where that catheter is in relation to the patient's anatomy in real time. So the first step that we tackled was the catheter tracking system and integrating it with co-registration. We tracked catheter location and course via low-power magnetic field, co-registered that magnetic field with real-time patient anatomy. In our first iteration, we just used fluoroscopy. We were able to guide the catheter using our anatomic model constructed from these previously acquired imaging. An image loading engine was created to load and rescale the DICOM images to an isotropic volume. We used a Aurora magnetic tracking system with those particular characteristics. We created a simplified cardiac phantom to mimic the cardiac atria with a septal defect, so just 2 chambers with a hole between them. And we performed 40 standard catheterizations in which we crossed the defect. And then we performed 40 using our prototype. All catheterizations were successfully completed, and there was no significant time difference between the traditional method and that using our prototype. Total procedure time was actually lower using our prototype model. So from this, we concluded that our prototype had performed well, and we considered it a successful first step of the CathBot project. We were awarded a patent for our work. In the next phase of development, we look to focus on integrating the robotic catheter arm, as well as begin development of the catheter manipulation algorithm database. Much further off into the future, we plan to really build in the AI and use all of the different methods that have been discussed quite a bit at this conference, really to hopefully achieve goals such as CathBot being able to create and modify its own catheter manipulation algorithms, to evaluate and rank and improve upon these algorithms, and even begin to do some imaging interpretation, with the ultimate goal of procedural decision-making and to raise the level of procedural capability to that, and I hope above a human operator. Just want to say thanks to the folks I work with, and that's it.
I'll kick off, I guess. So when we speak to radiologists, we say, well, don't worry, the machine might be better at you at interpreting the images, but you'll always have a procedure.
Yeah.
But what you're saying is it's quite likely that, you know, for procedures like catheterization.
Yeah, I don't think it'll be while I'm a practicing physician, but you know, I realize how slow things move when you start to actually try and do them.
Yeah.
But it's easy to come up with an idea like this and plan it out, but to actually get the funding and the resources to move forward. But specifically answer your question, I don't think it's going to be my personal problem, but I think eventually it'll be a very slow process, but eventually we'll probably be moved back to more of a supervisory role, and then potentially even eventually not even that.
Are scared yet?
You know, one potential source of funding would be looking at DARPA. They like crazy ideas, and that is a good crazy idea.
I think you just called me crazy.
But what about vascular access as part of, would that be
Yeah, it's an excellent question. You know, I think in the Cath Lab we take it as sort of a very simple thing that we can just get done. I think that would be something that you would be able to use manipulation algorithms. I wouldn't necessarily call them catheter manipulation algorithms, but a series of robotic arm movements that should be able to accomplish vascular access, you know, especially with the use of ultrasound.
The way you mentioned the pre-cath radiographic data was you took what was available, but does this require that patients have well-performed total body CTs or whatever beforehand?
Yeah, so I did brush over. I did brush over that a bit. And obviously, if you're getting a pre-procedural CT, you're adding radiation right there. But to be more specific, the data would need to be acquired with the fiducial markers in place for our current registration system. So it would be a plan scan that would be a day or two before the catheterization. And so your anatomy obviously is very unlikely to change in a matter of 2 to 3 days. But it certainly wouldn't need to be CT. It could be MRI or even ultrasound, depending on what type of anatomical model you needed.
the complexity of, as you know, getting a wire into, you know, a abnormal anatomy, into the right ventricle, out into a PA that's stenotic. I mean, that's part of the goal.
Yeah, and I think, you know, I think that's probably why it'll almost be impossible to remove the human element to this. You know, in the middle of my procedure, something can change, and, you know, the cognitive ability to recognize that, deal with it appropriately is really astronomical when you think about it. And so I think, you know, the reality of completely removing supervisory role, you know, of a human is, I think, incredibly far off. But I think, you know, technology moves forward, and it seems like it just keeps moving forward quicker and quicker. So I think that once you started with the basic procedures, that it would hopefully learn and be able to learn from other procedures that it has done, pattern recognize the situation, and potentially, in some cases, even better than a human operator would. It would have all of that patient monitoring data coming in at the same time, and might be able to pick up subtle changes in that we wouldn't have.
Thank you very much.
Thanks.
Glimpse to the future. And our last speaker for this session will be Eden Rom in the Precision Medicine and Drug Discovery. Welcome.
Hello, I'm Eden Rom, and I'm here to present on the work I've done developing a machine learning model to predict novel beta-secretase inhibitors. Beta-secretase is an enzyme involved in the process of the development of beta-amyloid, which is a plaque responsible for many of the symptoms and problems associated with Alzheimer's disease. And so what's interesting about this is that although my project was specifically for beta-secretase inhibitors, this scheme can be transferred to other searches for molecules with a specific function, given that you do have a bulk of molecules with similar functions. So the first step is to compile your data. I made two sets, one of 52 inhibitors and one of 48. These were obtained from the RCSB database, protein data bank, and I extracted the inhibitor structures from the X-ray crystallography structures of them in complex with the protein that they are inhibiting. From there, you get the SMILES name of the inhibitor, which is just a structural representation, and you're able to go on to the next step, which is to use a software like Paddle to calculate a set of molecular descriptors, which are just physical, statistical, and chemical ways of representing the molecule. They might represent the number of a certain atom. They can represent the energies of different pieces and their responses to different environments. So this program gave over 1,500 descriptors, of which 1,264 were not constant between them. All the constant ones were removed as they don't provide any sort of profiling information because they don't vary. Next, I wanted to determine which of those descriptors actually provided a positive amount of information to the problem at hand, and I wanted to order them based on the amount of information they give to the problem. This was not only to get rid of descriptors that weren't useful, those being the ones that provide zero or negative information, but also to be able to determine the point at which the point at which you don't need any more descriptors to achieve maximum accuracy, because that reduces the runtime and you get faster results, and that's good. So that's where I applied the InfoGain attribute evaluator, which ordered my descriptors and gave 483 of them positive values for information gain. All the other descriptors were eliminated. And then I applied this set of ordered descriptors. I put it into my machine learning program, and I applied 3 different functions in a 5-fold cross-validation to these descriptors, and in different amounts. For example, the first set might have had only the top descriptor. The second set would have had the top 10. The next one would have the top 20. And I did this all the way until all 483 were used, and you plot the accuracy and ROC area, kappa statistics as a function of those, of the number of descriptors. And then in order to validate my results, I used this first set of descriptors to predict molecules in a second set that's completely independent from the first one. And I got similar results with one of the functions, which is the multilayer perceptron, which is not a deep learning algorithm, but it is the most sophisticated machine learning algorithm I did use. And then in order to see if there were, if particular molecules were causing significant source of error, or just to fine tune the function, we did a structural alignment between the inhibitors that were used in order to remove ones that caused problems both in the structural alignment and the machine learning, which we did find that the ones that were commonly predicted incorrectly by the machine learning program were also clustered separately or in clusters that had many inaccurate representatives. So these are just two X-ray crystallography structures of beta secretase in complex with inhibitors. These are examples of some of our inhibitors. And then these are the results. I have MLP highlighted, that's multilayer perceptron, because it was most accurate between the two data sets. The top one being the data set with the first data set off which I built the model in the 5-fold cross-validation, and the second being the model that I used, the one where I used the first model as my, to train, and then the second one to test, the second set of data to test. Yeah, and that's all.
So with your results, you've come up with a limited number of compounds that are potential drugs, is that right?
Oh, so there's a next step to this, which is applying the model, now that it's been validated, to a large set of molecules, like the NCI database, which has a couple 100,000 molecules, and it should be able to pick out potential molecules that will be inhibitors of this enzyme. And once we do that, you go on to lab testing and all of that to see which ones really work, because this is, this just tells you some statistics. It doesn't, you don't know it works. Yeah.
Can you just maybe say a little bit more about the features? Were they sort of 3D structural features of the molecules?
So we only did 2D structural features. The program does have an option to do 3D, but they aren't, there was an emphasis in some of the earlier talks on the quality of data, and the three-dimensional descriptors are not as reliable. And so we figured if we can get an accurate enough model without using them, then that would be better. And we were able to do so. And I also want to apply the deep learning algorithm later so that we can possibly even increase the accuracy.
I had a question about knowledge sources, whether you use, there are many biomedical knowledge sources available, and I was wondering whether you use them or whether you see opportunity to use them.
Sorry, to use what?
Available knowledge sources on the web for biomedical knowledge, so for instance drug bank or other kinds of sources.
No, we only used pretty much just information from the RCSB protein data bank, and then everything else we did ourselves.
And do you see whether it's possible to exploit this more, for instance,
yeah, I think
for in the data part, to enrich the data?
I think that any situation where we have the problem with the inhibitors that work for beta secretase is that they're all toxic, so you can't actually use any of them in humans. And so we are characterizing the parts of them that make them an inhibitor of beta secretase, and then finding molecules that might not be toxic. And so this concept can be applied to basically anything where you're relying on a small molecule to cure a disease, but the small molecules you found to cure that disease also harm humans. You can come up with a profile of them using your machine learning models and then predict new molecules with similar functions and then be able to test those. And if they should have similar functions. Given that they don't harm humans, you'll be able to use them as a treatment.
nice view.
Yeah, it's exciting.
Can you help put this in the context of other molecular screening programs, algorithms, AI approaches that have been available? What's unique about your approach to, there are myriad programs to compare, to look for molecular
I mean, what I really like about mine is that maybe the way I said it wasn't so, didn't make it seem that simple, because maybe I jumbled my words, but it's actually very simple to do, and it doesn't take much time. And the programs I use don't require much knowledge of coding, or any really at all. I used Weka. If you know, Weka doesn't require you to know Python or R or any of that. So I think that what's good about this approach is that it allows people outside of AI to be able to use some of the tools, given there was a problem the black box brought up. But if you do trust in the information the black box is putting out, if AI does gain rapport with people and it does, like let's say, when people are able to get in those self-driving cars, and even when they have, when they are proven better than people and people know that they're safe, when AI's gained that rapport, we'll be able to trust algorithms and not know how they function. We just know these are results and they can be trusted, I guess.
So thank you very much. And can we please thank all the presenters, because it's been a fantastic session.